Okay, good morning, everybody, and welcome to day 2 of eHealth conference. My name is Badrun Tege. I'm a board member of Isteco from Uganda. I'm also a fervent technologist and a regional enthusiast, and I'm glad to be here. Let's move on. We have a very busy morning with a lot of interesting information to share. Let's start off with inviting Dr. Ernest Dako, founding partner for Broadreach Corporation, who will tell us a little bit more about himself and proceed with his presentation. Doctor, please proceed. Okay.
Good morning, good people, and greetings from very cold Cape Town, South Africa. I am Ernest Darko. I'm a medical doctor by training, also have a Master of Public Health and an MBA. I'm very passionate about population health and public health, in particular in our African context. And our company, the Broadreach Group, we basically do two things. We first and foremost provide support to countries, governments, donors, NGOs on solving their big business challenges or their big program challenges using technology. And then second, we provide technical assistance and direct service delivery support to countries who have critical gaps in resources on an as-needed basis. So as somebody who has been, I've spent most of my professional life in public health in Africa, trying to deliver large-scale programs. And I use the term delivery very deliberately in the sense that not just advising, but literally delivering. I've worked in government, I've worked in private sector, I've worked in NGOs. And one of the things I wanted to really focus on was the fact what I've observed around our approach to digital transformation as relates to big agenda items like COVID-19, or universal health coverage, or primary healthcare reengineering. And I'm grateful that you've all are here and honored to be able to share my thoughts on this with you. So COVID-19, I believe, has taught us three primary things. Number one is that we urgently need to fix our health systems. We realized through the experience of COVID that, in essence, our health systems have been quite broken fundamentally, and that in order to address something like what's facing us, we urgently need to fix things, and we're seeing the mobilization to that effect. We also, number two, have to focus on the true definition of health, i.e. addressing physical, mental, and social well-being of our people, not just the disease of itself, because as we've seen, COVID touches everything. It touches the economy. It touches the fact that, if you do not have basic services like water and electricity or good housing, people can't take the measures required to actually protect themselves. So it demands a whole government response. And we're seeing, again, it's forcing us into that type of mobilization and into that type of configuration to respond. So I think the third thing that COVID has taught us is that we cannot depend on others to prioritize us before themselves. And we've seen this with the issue of the vaccines, first and foremost, the wealthier countries hoarding the vaccines. Secondly, as they've launched their vaccination programs, they're, for example, prioritizing vaccinating their children when we are struggling to vaccinate our over 60-year-olds and do not have the resources. So in many ways, we realize that for now and for the future, we have to do a lot better in terms of taking care of ourselves. So the reality, my esteemed colleagues, is that in the current status quo of our local resources and capabilities in most of our African countries, if we go in a head-to-head battle as we are with COVID-19, most of us are going to lose because we cannot respond adequately. Each wave, as we've seen, of COVID-19 has sort of come and gone, and it's killed people, it's wreaked havoc on our economies. And for the most part, our mitigation measures are just not matching the epidemic at the level of its intensity yet. So we need to figure out how to do this. And I asked, could we have predicted that we'd struggle badly with COVID-19? Of course, because we have struggled with all other diseases and health issues for decades: malnutrition, malaria, diabetes, hypertension, cancer, Ebola. So, we have for the most part not been able to manage those effectively, even though we've had decades to manage many of these things. So, not, not only have we failed to tackle these diseases, we've also, I think, for the most part, also not done well with achieving long-standing agendas, for example, around primary healthcare revitalization, as articulated in the Alma-Ata Declaration. And more recently, I think we all know that universal health coverage is a priority, but we've struggled with operationalizing this and driving it to scale aggressively. As the continent with the largest burdens of diseases and the lowest per capita level of health resources to address those diseases, our only answer must be and is innovation, right? When you have David facing Goliath, right? David did not go after Goliath, to try and wrestle with him or to fight Goliath on his terms. David had to innovate and use a technology that would enable him to bring down a giant, right? So similar to our situation, when we look at the burden of disease, that's our Goliath and we are the David. What are we doing to innovate so that we could actually survive this, overcome this, and not just overcome it, but thrive as a continent and as countries in the continent? So the bigger the challenge we have, in essence, the more innovative we must be. Given that we have the biggest challenges on the face of the planet, the question then is, are we therefore being the most innovative in the world with what we have? Okay. So I'll let that settle in. If we have the biggest challenges in the world with the least resources in the world, are we being the most innovative in the world when it comes to addressing our challenges? Okay? So, and our lives literally depend on this, right? So, as we're seeing with COVID, this is real lives. I've lost friends, I've lost colleagues, we've all done so. So this is having a real impact on us. So it's not a luxury that we have to say, well, we're going to train medical professionals over the next 20 years. These are things that are facing us now. So how are we innovating? Are we innovating adequately with what we have? And then if that is still not enough, then what else are we going to do? So it's important that we get this right. We need to get it right for COVID immediately, but more importantly, we need to get it right for overall service platform issues like universal health coverage, because that will protect us against all present and future threats. As someone who spent most of my professional career obsessed with how we use technology and how we innovate better in the public sector across Africa, and as a developer of technology who's tried to scale up these systems in the African market, I think the best place to start for me now would be to say some of the challenges and mistakes I see us making consistently across the continent. And then I'll share some recommended solutions and approaches that I believe will better get us to this goal. So the first challenge, or what I call almost like a mistake, is that there's a fundamental flaw in our approach to technology. And that is we tend to take a technology-led approach, meaning that we buy technology and then we try to figure out how many problems can we solve with it. So I call this approach solutions looking for problems. And it simply doesn't work, ladies and gentlemen. It's a product of why we are where we are now as a product of this approach. Instead, I think we need to do the opposite, meaning firstly focus on clearly defining what are our management and business problems, our programmatic problems that are preventing us from achieving our goals and objectives. These problems tend to be problems with people and processes, not problems with technology per se. Then we need to define the best solution to these problems, and then finally assess the extent to which technology can or cannot enable those solutions. Right? So it's turning the approach on its head. Instead of starting with the technology, we start with what actually are we trying to solve, and then work backwards to the technology. The second issue that I've seen often is that the technology-led approach, it leads to a syndrome of us therefore not positioning digital transformation at the right level of priority or with the right people in our systems. So technology and data is usually seen as a domain of IT departments, M&E experts, or ministries of science and technology, instead of the president, ministers, permanent secretaries, right? This in turn leads us to not giving digital transformation the right level of urgent priority that it requires, or the kind of executive sponsorship or funding required for it to actually be successful. So in the same way that the presidents currently are visibly getting up and addressing their nations about COVID, giving the nation updates, we should similarly be doing this for digital transformation if we are serious about it. And we should be serious about it because our lives actually depend on it, as we're seeing in the case of COVID, and who knows what's coming next. The third one is we don't maximize the use of technologies, data, and experiences that we already have. Right? We've already invested billions of dollars in technology across our systems. We have reporting systems, management information systems, finance systems, lab systems, HR systems, biometrics. But we're not really getting everything we could out of them, right? And it doesn't make sense to be making big additional investments when we're not maximizing what we already have first. Also, I estimate that we do not use about 95% or more of the data that we collect currently. But yet, we find the pressure is to collect more data, right? Which again, we don't really use adequately. And then the fourth one is we maintain an environment and norms that make it difficult for innovation to flourish. Okay. And what do I mean by this? We tend to be, as government in particular, very risk averse, and we want something called proven innovations. Well, if it's already been proven and done 1,000 times, then it's not an innovation anymore. In fact, you're late to the game. When it would be like, the person who's buying a smartphone today, saying that I'm innovative because I bought a smartphone, right? But I wanted to see everybody else use it first before I bought it. Well, all you do is doom yourself to not having benefited from the early benefits that accrue from you having invested and taken the chance of innovating earlier. The second thing is we expect innovators with their solutions to come and find us instead of us finding them. And we make it, and then even when they do find us, we make it extremely difficult for those innovators to negotiate through our systems and ultimately provide their services and their goods to us so that we can actually benefit from them. And this is odd given that we're the ones who actually have the need and need to benefit. But we then still make it difficult for the service providers at every level to find us. We expect slow business as usual processes, like, for example, an existing procurement process that delivers procurement in 9 or 12-month timeframes to serve us well in an emergency. We come up with often, I'd say, self-defeating regulations, policies, and procedures. For example, in the early days when we launched our technology platform in 2014, most governments we went to talk to about using this to improve their universal health coverage efforts, to improve their disease management efforts against diseases like HIV, TB, diabetes. And the first response we get, for example, it's policy that we're not allowed to use the cloud, right? Now, this is the thing that is driving the economy of the world. It's driving it's changed the face of how things operate on the globe. And our first initial response is, no, we are not even going to do that, almost by law, right? So these are kind of, again, and making the environment incredibly difficult for innovators who have the things that we need. Finally, we often have internal structures. And I say, for example, the way we've organized our federal autonomous regions, districts, municipalities, provinces, that often have degrees of autonomy when it comes to making decisions on what they procure. Meaning that scale up now is what I call door-to-door guerrilla warfare, as opposed to scaling up quickly across a country with ease. So these are some of the things that practically get in the way of us being able to scale. And then you'll find, for example, in the country, people have procured, 15 different biometric solutions, 20 different, health management information systems. And then you worry about, we need to integrate these, and we spend millions, if not billions, trying to integrate them. And then those become vertical systems that we further need to try to integrate as well. So we've seen this over and over and over. And I've worked across directly in at least 20 African countries, and I've had exposure to many others through regional initiatives I've participated in. And these issues are syndromic, meaning they're common across all of our geographies. So how do we get digital transformation right and achieve large ambitions like universal health coverage or address COVID that is on us at the moment and wreaking havoc? First and foremost, I think we need to position digital transformation at the right level of priority with the right people to drive it. So it must be at the top of our development agenda and driven like a life and death priority that it is. What should this look and feel like? Ladies and gentlemen, it should feel like how we are currently addressing COVID-19. Okay? Presidents are leading and setting the tone. It's a whole country multi-sectoral response down to community level. Extensive data is being used to track our progress on daily, weekly, monthly, quarterly basis. Resources are being mobilized urgently from all sources, and everyone is engaged, right? Digital transformation must be the top leadership priority program for ministers, permanent secretaries, directors of health services, not the IT department or the M&E department or just a Ministry of Science and Technology. Although they are critical stakeholders, very important stakeholders in the process. As we're seeing, for example, with COVID, you don't have the Ministry of Health leading the response. It is the president leading the response for the whole country, mobilizing all the line ministries accordingly. The second thing we must do is we must take the right approach to technology. As I said, leading with technology first doesn't work. We must lead with a deep understanding of our business challenges, because often many of them have nothing to do with technology, and therefore technology will not answer them. So we must understand those and then back into the technologies that will actually assist us. Third, we must maximize the use of what we have already by unlocking the collective power of what we've already invested in. All those systems I mentioned, your HR systems, your finance systems, your HMIS systems, your DHIS, all of those things. How do you unlock what's in all of them to make them sing together like the proper choir they're supposed to be? Think of them as your digital orchestra, right? So what can we do to orchestrate them better so that they actually deliver what we need them to deliver collectively, not individually? And I think we could get a lot more out of what we have. And yes, there will be gaps. You'll realize I do not have a violin, or I do not have a bass player or whatever. But then you go and source that in a correct way. And you source that by and support it to grow by making sure, this is the fourth thing, we have the right environments that enable innovation to flourish. And that means, for example, creating point people and designated champions at each federal level of authority who interact. Those point people must have a deep understanding of technology, must have a deep understanding of how government works, and then they must work with champions who are designated at every level who can streamline the road clearing required for things to happen the way they need to. We need to radically streamline and enhance procurement processes in particular, because at the moment, many of these procurement processes are not compatible with getting what we actually need in the timeliness with which we need it, and to scale it up in time for it to actually help us and save the lives it needs to save. We need to go out and woo investors. This is a very different approach than what we're used to, where we maybe put out a tender and people must come to us and woo us. We must, based on that approach of defining our business challenges, we define what we need, we go out and find those innovators, we must make them offers they cannot refuse, giving them incentives, giving them ease of getting to be able to set up and work on their products, encouraging local entrepreneurs and supporting them to grow within our countries, because it's critical that we do so. And then providing explicit pathways for them to actually scale up their product, where we as government are the ones who drive the pathway, not expecting the service provider to be the one. For example, now you must go to my 5,000 municipalities and convince each of them that they need this thing. And right now I find often the service providers put in that position where they have to do this work. And then to partner with the private sector as a rule, not the exception. Ladies and gentlemen, I've worked with technology for the last 25 years of my life. It is not something, with all due respect, that governments can build, own, maintain. We do not have the institutionalization of the roles, the skill sets of these type in order to do this within government. And if you look at every leading economy in the world, they outsource technology development to the private sector, right? When the US government decided they needed cloud services, they didn't go and build their own cloud. They went and chose between Amazon, Apple, Microsoft, and they went and chose from existing private sector offerings. China does the same. You go across the world, it's the same. In our environment, often we find it's like we're trying to compete with the providers as opposed to actually figuring out a framework to embrace them effectively. And then finally, we sort of have to stop using lack of funds as an excuse. If COVID has taught us anything, it's the fact that fixing our systems is a priority and that we can mobilize from various sources the types of funding we need to save our people. So in closing, ladies and gentlemen, I believe that it is imperative that we use COVID as an opportunity to springboard us into universal health coverage. Our response to COVID is a practical modeling for us of the kind of response we need in order to achieve universal coverage, right? And it's important that we achieve this not just because of health, but because these technologies represent what is referred to as the fourth industrial revolution. In Africa, we have missed the first revolution, we've missed the second, we've missed the third. That's why we have no jobs for our people. That's why we have high unemployment rates. That's why we are at the back of the line when it comes time, for example, with vaccinations, where other countries prioritize themselves and don't prioritize us. This is our chance to participate in the world in terms of growth and economic productivity on an equal footing. So it's more than just being about health. But health is a good proxy for how we're going to perform in the fourth industrial revolution because it's multi-sectoral. And how we perform, therefore, in health is a good indication of how we'll perform overall in this issue of digital transformation. At the end of the day, ladies and gentlemen, when you look at countries that are progressing in this issue, I'd like to give an example of I was speaking with the vice chancellor of one of the big universities here in South Africa. He had gone to a top university in America to learn of what best practices they were doing as a university in order to see if there were things he could bring back to South Africa. And he related to me that this was about 2 years ago. Every single student at that university, and it's a really big university, every single student, if you look at the entire student body, 85% of them had technology in their degree. That's part of their degree. So they may have been doing a degree in biology, but they have a minor in technology, right? And I'd like to ask if that's the case where 85% of students in other countries in university all have technology as part of their degrees, where are we? And what does that mean for us if we don't get on this bandwagon quickly enough? So with that, ladies and gentlemen, I really would like to thank you for your time. It's been an honor and a pleasure, and I look forward to what I'm sure will be a really fascinating discussion going forward. Thank you.
Wow. Thank you, Doctor. I was fervently making notes here. Thank you so much. Let's move on to Dr. Patricia. We'll come back and really make this. I really like how you've kicked it up. So Dr. Patricia Odero, who is a Regional Director for Africa, Duke Global Health and Innovation Center. Dr. Patricia, please take the floor and let's proceed. Thank you so much. Doctor, thanks for using your time excellently.
Okay, thank you so much.
Dr. Patricia, all yours.
Thank you, and good morning, everyone. My name is Patricia Odero. I am with Duke University's Global Health Innovation Center, and I'm part of a consortium that actually works with Broadridge, the organization that Dr. Dakpo is part of, and also have other partners, two regional economic communities, as well as gender health systems. And so three objectives or three things that I hope we will take away from this morning. I want to share some milestones as in the process, a multi-year process of developing Africa's first regional health data sharing and protection policy, and then also draw out some applicable lessons from this complex policy-making process. And we believe that these lessons are, have applicability at national, regional, and global level. And then thirdly, be able to provide recommendations that would be able to support similar processes, because we believe this aspect of data governance or enhancing data governance through policy and regulation is something foundational that will enable digital transformation, as our keynote speaker pointed out. And so we definitely know that other regions in Africa will follow suit, and we hope that we'll be able to provide some thoughts and some insights from what we learned. So back again to just talking about the regional action through data. This has been or is a 5-year initiative funded by USAID's Global Bureau for Africa. And it's an interesting project because it is a co-designed project. This is basically very responsive to what are the challenges facing regional economic communities. And we work with 2 regions in the Horn of Africa, IGAD, the Intergovernmental Authority on Development, and in West Africa with ECOWAS, the Economic Community of West African States. And we work with them through WAHO, which is the West African Health Organization, that is the specialized organ for dealing with health in the ECOWAS region. And underpinning this support are 3 areas of technical support. Broadreach does work at the regional level around aggregating information. Then my colleague Martin Weiss, who's going to be a speaker later, will talk about the work that's being done at the cross-border patient-provider level. And then our team supports both regions around policy level. And I believe some of that work may be highlighted later in this discussion. And so with that context, want to take a deep dive in what we've been doing over maybe now close to 4 years within the IGAD region. This is quite a dense slide, so I'll just walk us through from the top. What has happened in 4 years. Trying to put that on one slide is always a challenge, but I will do my best. And so essentially for the first year, we started out, as I said, this was a co-design project, identified challenges around driving evidence-based decision-making, leveraging data for health data and health-related data to solve public health problems or issues as a major constraint. And as we undertook this landscape analysis, it was clear that there was no the policy framework underpinning some of the changes or the transformations that we saw as necessary to leapfrog some of these challenges was missing. And so there was a lack of legal or regulatory frameworks around data sharing, sharing of data between countries and regional bodies, sharing of data between countries, or even sharing of data at the patient-provider level to enable continuity of care for patients who are moving from one country to a different country. And then there were also inconsistent standards and policies around data protection, because the other side of the coin on data sharing is that then you have to make sure that data is protected as it's being transmitted and shared. And then also there were also inconsistent patient confidentiality and privacy laws, and that those 3 challenges hampered the level to which countries could share data with each other and with regional bodies to be able to allow for aggregation and analysis. And so with the IGAD team, we then had to decide whether to develop technical guidance on this topic of data sharing and data protection, whether to develop a policy, or whether to work to develop a law that would be legally binding. And in the end, the best solution was actually identified as a policy, a regional policy. So one policy with consensus and covering 7 countries, and those countries then would domesticate and adapt and integrate the principles of the policy. And so that was done in 2018, and this was endorsed by a steering committee made up of IGAD member states, and recommended then that IGAD drive forward and move forward with this initiative. And so the first draft was written in 2018, and initially we had thought that by the end of 2019 we would be able to have achieved significant consensus. And so we were, I think, on target. We had done 3 countries, Djibouti, Ethiopia, Uganda, by the end of 2019. And, as last year started, we're on high gear to finish up with the other 4 countries. Unfortunately, the COVID-19 pandemic happened. And so therefore, the engagements, and I think as you may be aware, achieving consensus on something that would be binding in a sense, even though it's a gentleman's agreement, as is in a policy, across several countries, is a delicate balance, negotiating, agreeing on what are the minimum standards. And so often, or the best way to do this is in-person engagement. However, with the pandemic, we then had to shift to virtual engagements and try and make the most meaning out of those engagements, find creative ways to be able to bring in multiple stakeholders and not just engaging with... Yes?
Doctor, we're losing. There seems to be a link problem. Do you have another slide, or can we the audio, the video, and see if it makes better? Because your audio is very distorted.
Okay. Let me see if let me stop sharing and see if by removing my video, we could be able to get it better. Thank you. Okay.
Yes.
Okay, thank you so much. So as I said that I'm not sure where I cut out, but then just had been walking us through the process, how we pivoted to undertaking virtual engagements, and which we tried to ensure that they were inclusive, even though they were undertaken virtually with 4 countries, Kenya, Somalia, Sudan, and South Sudan. And so this slowed down the process, but then now in 2021, we have been able to achieve consensus and are just looking forward next week to the validation and ratification of this policy. And so just want to give a very quick snapshot of what the policy has, and before diving into the lesson. So the IGAD member states have agreed on 6 data sharing and protection principles, which are captured in this slide. And those are really guidance or guidelines that will underpin how data is shared and how data is protected within the region. And so the first principle is around legitimacy, consent, and transparency. Then the second area is around purpose and relevance, that data being collected should be for a specific purpose. And then on the area of protection, that data collected should be, stored confidentially, should be collected in a confidential manner, stored and secured, according to the highest standards, just in managing the cybersecurity risks around data. And then that data should be shared and transferred in a standardized, secure and accessible and timely way. Then those limiting or just being clear around who has access to data, especially also making sure that data subjects, because data is owned by the patients or the data subjects from who are the ones from whom it's collected, also have the right to access that data. And then finally, which is a big hindrance in our region, around making sure that there are minimum standards on the quality of data that is shared. So those are the 6 principles. And then on the other side, we also wanted to emphasize the rights of data subjects, because sometimes we have found historically that sometimes data is collected in a really extractive way, in the sense that basically the data subjects, or those whom from the data is collected, do not have a voice, and therefore are not able to even sometimes provide informed consent on the data, that their health data. And so the countries, member states agreed around, information, providing information in terms of, how the data will be used, being able to, as far as possible, allow access to the data subjects. Then this is something I think quite new in our region, but is based on global standards such as the General Data Protection Regulation in the European Union. The right to rectification of or erasure of data of records on the request of data subjects, and also the rights of people to object to the disclosure of their personal health data. And then very significantly, this aspect that countries commit to allowing data to be portable, that basically data can be transferred from one data controller, that's the entity that's managing the data, or a data processor without any hindrance. And so that aspect of portability is something that we believe will be foundational for solutions and technologies that support continuity of care across borders. And then, of course, we do have some exceptions to make sure that the rights of data subjects are not impeding, some public health safety measures. And then lastly, I think we also identified that this will be to be able to implement a data sharing and data protection policy, that it will be necessary to have multiple stakeholders. At the center of it all, it's, communities from whom data is collected, but who also we hope public health interventions that are driven by that data benefit. And then there's health workers, and other implementers, private and non-private sector and other non-health sectors. And then we also have now the layer with the data processors and the data controllers. And then in this case, then there is the governance, so IGAD and its member states. So I think the key achievements through this 4-year process has been then, of course, the finalization of this first regional health data sharing and protection policy. And then additionally, being able to achieve consensus through a multi-stakeholder process in 7 very different countries. And then also being able to adapt our engagement modalities for this complex process in response to the COVID-19 pandemic. So we think that this is something unique and, achievements to be shared. So the lessons that we have learned, I think 3 areas. I think time and patience, that complex processes often are iterative and do require more time. It's not that the first time you engage, member states or everyone will be at the same level or will necessarily have agreement on, the value proposition that you are presenting. In this case, around, the benefits of data sharing, cross-border data sharing and data aggregation. And so you require time and patience to steward these processes effectively. And then also that this policy processes such as this require to be inclusive and collaborative, that often we engage just with line ministries or the public sector. However, in a lot of our countries, health markets are, mixed markets. So there is a predominant private sector component. And so you need to bring on board private sector health and private sector non-health to be able to create the right incentives, to be able to make sure that you have the right sets of collaborators so that when the policy needs to be translated to action, then the right people are at the table and are willing to take it forward. And then I think the last thing is that for us, while the pandemic will present many challenges that I have outlined, it has also, I think, provided impetus for the countries to move forward with this, because then there's already just immediate use cases for what the policy is. As people are moving from one country to another, you want to be able to have them, carry their health records, and for those health records to be shared in a confidential way, so that you ascertain, for example,
the next minute, please.
Yes, their COVID status. And then, so our recommendations are that regional economic communities, in collaboration with their member states, should lead the development of contextualized data governance policies that respond to the needs in their specific countries. Secondly, that implementing regional data governance policies provides a platform for collaboration, which then allows countries to meet current and emerging public health needs, such as the ongoing pandemic. And finally, that regional data sharing and protection policies do provide a foundation for evidence-based decision-making, which is clearly critical in order to advance goals such as universal health coverage. And with that, Thank you so much for listening, and looking forward to questions and engaging.
Thank you so much. And I like the way we fixed that issue. Let's now go into our second presentation from Dr. Serge Somda, who's a methodologist and biostatistician from West African Health Organization. Doctor, can you wave if you can hear us? You can hear us, but we cannot hear you. While admin works to support Dr. Somda, Dr. Saj, Ahmed, Bashir, and Martin Weiss, are you gentlemen ready for us to move to that? We can use time better, and then we can come back to Dr. Serge after.
Sure, not a problem. Just give me 1 second to get the presentation going.
Great, thank you.
Just a little bit of my background. I'm an electronic engineer by birth, I suppose, and a technophile. But I think the words of Dr. Ernest ring so true in my ears about how we implement technology without actually understanding what we're doing, and pushing technology as a driver instead of looking how technology can become an enabler of some of these solutions. And I wanted to quickly put in this implementing innovation in our region. I wanted to put implementing unproven innovation in our region. I think that's a fantastic slogan, approved innovation. So just a little bit about the area in which we work, our landscape. We often hear about our constrained resources in our region. So transport is a constrained resource, but it actually isn't. We have transport in the region. We just have to make use of it in the right way. Same as electricity. There is electricity. It's not robust. It's not always available, but it is there. And if we can make use of it in the right way, absolutely we can make use of electricity. Same as telecommunications. We have quite a robust telecommunications network. You can't get YouTube download in high definition in all areas, but you can move small bits of data around the country, and it's pervasive all over the place. You just have to make use of the right technology to get those little bits of data through. So together with our partners Broadreach, this project was funded through USAID. And with support of IGAD, we developed a cross-border immunization program for cross-border populations. And there are challenges around cross-border populations. They don't want to be identified. You don't know who's on what side of the border, and you don't particularly want to know because you're dealing with a disease, not with a movement of population. So we developed a solution which is both offline and online. It's based on tap and pay contactless cards, which probably most people have got a card in their wallet, which is tap and pay based. It's used pervasively in transport and in banking today. But to date, it hasn't really been used in public health. And this was an innovative approach in providing an anonymized way of a patient moving information across borders. The history of the immunization is actually stored on the electronic card, and I think that's quite important. So the whole history of the patient's immunization is stored on the card. And again, I need to emphasize that it's stored. The immunization history is stored on the card. Oh, sorry about that. What we did is we've had a look at how people engage with this kind of technology, and if you have a look right through Africa, all the mobile networks have this concept of a starter pack. So we built a starter pack concept, which is very much based on how mobile networks provide SIM cards to people. It's an accepted means of providing these kind of cards. The data that we collect is interoperable, and we rely on standards to ensure that this data can be used by other immunization programs. It can be integrated into other immunization programs as well, which ensures that there's a greater uptake of these solutions. And then it can be extended and secured to include other health events such as COVID vaccinations, HIV, monitoring of viral loads, yellow fever, etc. The solution I'm talking about now was implemented in October 2018 in 4 clinics between the border of Kenya and Uganda. To date, we've issued about 20,000 cards and recorded over 140,000 immunization events. And one of the main numbers that I see is that we have a patient retention of over 97%, which means patients identify with the solution, they identify the branding, and they're coming back to the same clinics or the partner clinics where the solution is being implemented. We're able to track a whole bunch of analytics around movement of people, around usage patterns, around immunization records. That's part of the data mining. We've replaced only 100 cards in the last 2 years, which means that patients are actually looking after their cards and seeing this as a solution. Another interesting thing is we only trained eight healthcare workers initially in 2018, and to date there are about 25 healthcare workers that are using the system, which means that they are training each other and they are learning from each other how to implement the system without additional training from our side. It's proven to be robust. We have had less than 20 hours in total over the last 2 years in these 4 clinics. So how does it work? I have some video clips which we can go through. So the healthcare worker has a card, an identification card, which she taps onto her phone. She then types in her PIN, and that PIN is only stored on the card, not on the phone. And that gives her access to the application. When the mother arrives with the infant, the healthcare worker takes the mother's card, taps it onto the phone, and then the immunization history is exposed on the phone. The healthcare worker can then provide immunization. She can modify existing immunization events. For example, here she's selecting out of stock, and you can see there's a visual line which changes from green to orange to indicate that the solution, the event has not been completed, updated. The healthcare worker then takes the patient's card again, taps it, and that information is then stored onto that plastic card. So the patient walks away with the completed healthcare record on her card. At the same time, we take that information and we send it up to the cloud as a backup. In the clinic, we install a box, which essentially looks like a bathroom cabinet, small bathroom cabinet. And inside that, we have our technologies. We have embedded servers, mini servers, and we have backup battery, and we have a Wi-Fi hotspot. So the system is able to look after itself for up to 12 hours on its own battery. It works off both mains and solar. It becomes a charging station for the immunization devices, and we've also made it available for the healthcare workers to actually charge their own phones. You know, it's kind of, we know that as soon as a healthcare worker sees a USB port, they're going to plug in their phones. So instead of them fiddling with our technology, we've made it available for them so that they can charge their phones. It also means that they tend to look after our technology a little bit better because it provides them with something. This platform that we have built, this connectivity box, is also able to host a whole host of other applications in the future, such as DHIS2 or OpenMRS. So it provides a local presence for other applications. Detailed reports, for example, here we can have a look at health impact. So we can have a look at immunization events per clinic or per country. We can have a look at cross-border visits, how many patients are crossing the border per day, per month, per week. We can also look at the number of health workers that are enrolled in the solution. How many have been registered? How many have been activated? How many administrators are looking after the system? We can also see numbers around the operational aspects of it. So downtime, we can monitor the recharge information per device, so we know when to send additional batteries. And then finally, kind of a last slide, that just some thoughts that technology in itself is not a solution; it's an enabler, and there are far more important aspects around implementing new tech and innovative tech, and that's governance. How does the ministries support these kind of products? How do we get donor alignment? So, just implementing a solution without getting a donor, without aligning the donor to what the needs of the government are, is a recipe for failure. And then, the other typical ones are how we need to ensure that users are able to accept this technology, that it fits in to their framework. It doesn't add additional work, but it needs to be seen, and it actually practically needs to reduce their workflow. How do we provide local support so that we don't have to buy special batteries from a Swedish manufacturer? That's where the logistics becomes impossible. And then not all technology needs to be high tech. I think there are appropriate technologies that we can use in our environment. And then finally, just that the system can readily be extended to track COVID vaccinations. There's no real difference between COVID and any of the other vaccinations that we've been doing in Africa for the last I don't know how many years. We're also able to integrate the solution with some of the work that's been done around digital certificates for travel predominantly. And this might become a way to replace the yellow card for vaccinations in Africa as well. It doesn't necessarily need a phone, which is the beauty of it. A patient can just, have a card, just like a banking card. That's it. Thank you very much.
It's very, very interesting. Before I share everybody else, I wanted just to turn around the question on you. How do we turn these solutions away from needing donor support in terms of where they can monetize themselves? And if the donor comes in, that is good, that is good. But how does that solution, how do we get a solution out without having the donor conversation? And this is a general question, but specific now to your solution.
Yeah, so it's a fantastic question and something I've been grappling with. Yeah, my background has been in corporate and in private sector, and I find myself in public health in a non-profit organization. And sustainability, I think, in all of these projects and these programs is a huge issue. We implement things and we push them out into clinics, but there's no sustainability. And in 2 years' time, these things just die. It's called pilotitis, where we just pilot things and then just slowly watch them die. I think for me the highest priority is governance. If we have ministries buy into what's been done, and that kind of forces the donors to align with the ministries and provide funding to get the pilots done. Once the pilots are done, I think the adoption into the fiscal becomes a lot easier. And again, as Dr. Ernest said, there's a lot of technology that's already sitting within government. For example, these cards that we are manufacturing. A lot of governments already have an ID card system, and there's no reason why we have to rely on these cards. We can make use of that card system that's already being rolled out. Also, I think making doubling up on the enablement of the technology. For example, this connectivity box that we develop is not just for immunization. It can host a whole number of other applications. And that brings down the life cycle cost of such projects. I hope that answers the question.
Oh yeah, I was just going to say, I think we have to move to a mindset where there's some things you just accept that you have to pay for as government, and it's important for you to pay for them in particular when you want to set the agenda. Donors, by definition, will have very narrow vertical interests. I only want to support HIV, or only children, or only this. If we're going to actually progress, governments have to basically make a decision and say, is this thing important enough for us? And I'd like to think that, given everything we've heard on this call, that these are life and death priorities. So we buy all sorts of other things, right? And yet sometimes these technologies we're talking about, it's not that they're more expensive than anything else we buy. It's just that it's not a priority for people to do that. So I think it really is a matter of elevating this, like I said, like the way we've elevated COVID, and really saying it is a priority, and therefore we're going to do the kind of mobilization from local resources. And if we don't have enough, we'll go out to investors and donors to fill the gaps on a temporary basis, because we do this for everything else that we bought technology for. For some reason in health, we're just slow in adopting.
Great. Thank you so much for that. Thank you so much. Dr. Saj Somda, are you ready?
Okay. So thank you very much. So after talking about technologies for data collection, data management, maybe we'll talk about the outputs. So we are going to talk about the health information products, because with the RAD projects which are run with Broadreach and the partner institution like IGAD and WAHO, we also have a components where we are looking at building and making available health information products. So this is what I'm going to talk about. So I'll give a short background on the West African region and the health organization, and go through the products. First, the digital platform, which is currently live, and then the physical products we manage to make available. So about ECOWAS, it's the economic community of West African states. So it's gathering 15 countries, so around 5 million square kilometers, and around 400 million population. And as a background, you can remember the Ebola outbreak we had in 2014. So before the outbreak, we have a very, very huge number of different solutions for data management, solutions for data collection, data management, and also information to produce information production. And it was not locally managed, it was project-based and so on. So after this outbreak, we had the initiative to gather all this stuff into one single platform and try to coordinate it at regional level. So in terms of products, first was the platform. At regional level, we have a platform based on DHIS2 technology. It started with epidemic-prone diseases. Then we added some components such as animal health. We are working on service delivery data now to integrate it in the platform. We had recent meetings with the nutrition program, and now it's the sexual reproduction health program. So we are discussing with the different programs to see how we can integrate them in the platform. And when we say integrating the platform, this means that we create solutions for the people in the country to directly either key the data, import the data, and now we are even working on automatic data sharing. As a background, should say that now all the 15 countries, all the health information management system of the 15 ECOWAS countries are working on DHIS2. So we don't have this interoperability problem. And now we are trying to make MOUs, to agree on MOUs between the countries and WAHO to automatically share the data, so to automatically connect the platform. I can give some results in terms of use. So in terms of reporting rates, you can see that when we had this Ebola outbreak, the reporting rate was quite low, like less than the half. And when the RAD project started, because it was low and it was even going lower, when the RAD project started, it was even less than 1/3. And with the RAD project, we started increasing. So at the apparition of COVID-19, we were closely to 100% with reporting rate. One other information which can give as a assessment, you can notice that for the first Ebola outbreak in 2014, it takes 4 months to notify the first case. And in 2021, when we had another Ebola outbreak in Zerekore in Guinea, the notification was made globally within 1 week. So this shows the strength of this platform, this integrated platform we have in the region. Additionally to the platform, now we are working on the live information, principally for COVID. We are working on a dashboard, which currently live. It's giving holistic information on the disease at the regional level. So I encourage everyone to go and usually visit this dashboard, which also made on DHIS2 technology. And this is based on the country official information. We are collecting the official information from countries, and we are using them to make the DHIS. So it's not based on information coming from elsewhere. We also made some modeling exercises. We produce internal decision-making tools. So based on our modeling, this helped to make decisions at the regional level as well as at country level, because all this information were shared with the ministers and the head of the National Public Health Institute. Okay, so after the digital solutions, I shall come to the paper-based I shall come to the documents we are working on. We have 4 main health information products we are using at WAHO level. The first is the weekly epidemic bulletin. So it's a kind of epidemiological newsletter we are sharing among the member countries and all the stakeholders. So this is giving the situation of the current epidemic. This is something which I've been working for more than 3 years, and we are still trying to improve it every day to automate it and so on. After the weekly bulletin, now we have the biannual health information bulletin. This is a new health information product we are proposing, and this proposes an extensive analysis on specific health questions. So for this, we go to meet the field professionals in order to give very, very large information. So the first version, which is yet to be published, but which will be very soon published, is giving extensive description on 1 year with COVID-19 in the region. Because the COVID-19 was notified the first time in the region in Nigeria, 27th of February. And the latest country to notify COVID-19 was Sierra Leone in the 31st of March, 2020. So we use the data from the beginning to the 21st of March, 2021 to make this analysis. The third health information product is annual. It's the annual health situation report. And the annual health situation report has this specificity that is based on the routine data. The routine data, the HMIS, the health information system, National Health Information System are collecting and managing. So this is principally based on health service delivery, on health status, and also on intervention in health, such as vaccination, family planning, and so on. So we collect the data directly in the countries, and we prepare holistic tables. We prepare regional indicators which are published. And now the final health information product we are working on is this pluriannual. It's every 5 years. It's called the ECOWAS countries health profile. Why ECOWAS countries health profile? Because we have 15 countries, so we are managing to produce 15 health profile. So 15 health profile. This means that we are going on all the range of information you can have to assess the health situation, the activities, and the outcome in the country. So we validated a list of trust indicators. We have actually 88 indicators which have been validated by all the countries. And now we collect the data and we make trend analysis, situational analysis, and so on. So if I want to recap, additionally to the digital platform we have, and the COVID-19, the outbreaks, because people are calling it COVID-19 dashboard, because now it's focused on COVID-19. It's the health problem which is live, but it's an outbreak dashboard because the objective is to extend it to any ongoing outbreak. So additionally to this digital platform, we are working on these 4 documents which are regularly produced and made available for as well as decision makers, stakeholders, large public, and so on. So these are the different information I wanted to share with you. And thank you very much for giving me this opportunity. Obrigado.
Thank you, Doctor, and thank you for using time so perfectly. Doctor, am I to believe that all the countries are fully participating?
Yes, all the countries are fully participating, but yes, according to the documents, but when we take, for example, the case of the health profile, for the health profile, we are requesting the countries to produce their own document. So it's not just data collection, but it's also analytic and so on. So according to the competencies, the skills, and the organization in the country, sometimes we are struggling. So for the health profile, like currently, we have 10 countries out of 15. But the other documents, such as the health situation and so on, we have the 15 countries, and we are making regional indicators.
Oh, great. Thank you. Panelists, anybody wants to chime in with 1 or 2 pointers or questions for Doctor? I'm not seeing a lot of questions in the audience, but anybody else want a comment? I know, Dr. Patricia, this is a bit in line with where you were. Do you want to add anything onto this conversation?
Yeah, thank you. Thank you, Saj. Great presentation. I don't know if you want to comment about...
Dr. Patricia, are you there?
Yes, I was saying, can you hear me?
Yes, we can.
Yeah.
Okay, I was thanking Saj for the great presentation and asking if you wanted to talk a bit about the data governance, the foundational internal policies that WAHO has worked on, that have and how those policies have built trust between the institution and its member states around sharing data.
Thank you. I was even planning to
great
come
question,
in with this. Yeah, I was even planning to come in with this question, because even when we started, when the RAD project started, and we tried to make an assessment, we noticed that we have this weakness, and this is not. This was not only at the country level, even at the regional level, we didn't have one single data governance policy. So it's difficult to ask countries to share their data with us, or to share the data among themselves, when they don't have specific documents describing how the data will be handled. So we started the project at the institutional level. So within the RAD project, so with the support of Duke University and Broadridge, we managed to get the data governance policy for the institution, so the WAHO data governance policy. which was validated at the Assembly of Health Minister, and which was even sent to the higher level, so at the Council of Head of States, and this was validated. And once, as we have our data governance policy, which not only dealing with health data, but is dealing with financial data, with staff, human resource data, and so on. So every kind of data. Now we are working toward the countries. We first made an assessment, so with the support of Duke University, we try to assess the availability of the different data governance policies at country level, and then we are assess the gaps, and we are going towards, but this needs to be done country-wise. So we are going towards now the different countries to assist them, to help them to prepare data governance policies, but to prepare the governance policies for the health data. So not specific for program data, or not specifically for one aspect of the governance, like security of data sharing, but we want a holistic data governance policy for the health data. Just yesterday, we were concluding one meeting with the One Health data managers, so the data managers of human health, animal health, and environmental health. And this was once again one strong recommendation which was made to the management and to the ministers. So we report this again and encourage the ministers to start this process. So in a few years, all the countries will have this document and will slide on it.
Thank you, Saj. There's one question for you: is where is the data repository of the ECOWAS data?
It's at WOW headquarters in Bobo Dioulasso, Burkina Faso.
Okay, great. Martin, I had asked you to look at the discuss list for some questions. Do you have some answers for us?
Yes, I do.
Yes, great. Take a few minutes just to respond before we get to Dr. Ain after.
So there were two questions. The one question is the medics are able to edit information on the cards, and does this not affect the legitimacy, or if that they can create new events but not edit them? So we allow healthcare workers to edit events. It's their responsibility in any case to make sure that those events are correct. We've tried to make this tool as open as possible, so it fits in with how healthcare workers and immunizers in particular do their job. So it's not a prescriptive mechanism of how they need to do their job. It's a tool. They will work out the best way to do it. They've been doing immunization for 20 years. There's nothing around the process of immunization really that we can teach them. What we do, however, is if changes are made, we do track those changes, and we use some of the blockchain type technology to ensure that the audit cannot be edited and changed. So if any changes are made on the card, they are tracked and they are visible. I hope that answers that question. The second one is electronic engineering in health is slow in Africa. We have been growing in terms of software, but from the angle of electronic engineering with health for Africa, this is so good innovation. Thank you for that. So again, back to what Dr. Ernest said about proven innovation. This card mechanism, for example, is not new. It's not radical. In my previous life, I've been using these cards for implementing security systems, 15 years ago. So the technology is not particularly new. It's just the application in health that is new. And I think one of the opportunities here is we need to start engaging with other domains, other skills domains, and adapting some of the technologies that they have built. There's a lot of work being done, for example, vehicle tracking. And there's technology in that vehicle tracking that allows us to reduce the amount of data over mobile networks to minuscule amounts of data. Those are things we can start implementing over health. Queue management, for example. How do you manage queues? in shopping centers. The trick, however, is to try and engage with these corporates and to get these secrets out of them with exposing those secrets to their competitors. And that's quite a challenge. So I hope that answers that. I think there's a huge opportunity in Africa for electronic engineering. But what is a challenge is trying to get this innovation as part of a program. A lot of the donors are looking at health impact, and it's really challenging trying to sell an innovative technology when your donors are looking at a health impact. You have to kind of smuggle it in under the radar and then hope that it pops out somewhere.
Thank you so much, Matt.
Sure.
Thank you for that. I'll definitely get back to you after. I'm Dr. Ain Avixo.
Thank you very much. Can you see my slides on the screen?
Yes, it is, sir.
Wonderful, wonderful. Thanks so much. I'm really stunned about the level of new information that I've already gathered from this conference. So, so I'm really humbled and thankful for the opportunity to share maybe something useful in addition to that. But I'm looking forward to the discussion already. I come from a company that is already 14 years old. And myself, I'm a chief medical officer there, so I'm a trained medical doctor and been bridging between healthcare and IT for the last 20 years. So what I try to do usually is to translate between the IT specialists and medical specialists, and it has been a lot of fun. Well, some of that fun is also what I hope to share with you today. The company is actually something that is part of the backbone of the integrity of digital infrastructure in Estonia. Estonia started its digital journey now 30 years ago, and I can tell that part of the reason why digital solutions have been quite successful in Estonia, at least to my own and some other researchers' opinion, is because we didn't have too much money. So that what Dr. Ernest said, that it's a life and death matter, is not only because it's about health, but it really does help to get the efficiency and effectiveness with a much lower cost than, for instance, other much more affluent countries have built over the decades and even centuries. So that when in 2007 we had a cyber attack, then the country was facing a question that, okay, now we have started all digital, and if everything you know about your country and people and activities, yes?
Doctor, I'm thinking, are you the one sharing the file? I'm thinking,
I am sharing
again,
the screen.
we could do what we did with Dr. But has the admin got a copy of it? Can they share? Because your audio is losing.
Okay.
They don't have a copy, we can proceed.
Yes, but I will stop then. I will get my camera off so that the video feed will only have the slides. Thank you for the comment. So when everything you know is about your people and activities is in digital form, you actually need to be certain that whenever somebody else is in the future presenting that data once again, how can you be certain that this is valid and truthful and hasn't been changed? So that is what the original technology stack was meant for. And since 2012, many, if not most, public databases are protected with a similar kind of technology. And then what I'm telling you right now is basically follow up to that. Now, we started working, we have been working with the Estonian government for quite many years, and through that also the collaboration with the World Health Organization started, but that was even prior the COVID pandemic. And the idea was to make use of those experiences and technologies that have been successfully implemented in Estonia, and how to make that also used by other countries. And when the pandemic started, there was 3-4 months of hesitation. So can we do anything? Because we have a crisis ahead. And then obviously, as many other countries, also international organizations discovered that indeed we could make use of this crisis to actually promote the digital solutions. And then the Vaccine Guard was born out of those discussions. So in the end of the day, in a nutshell, what we are leveraging this technology for is to combine two workflows, which on the left-hand side you see are part of any immunization program. This graph, the schema is from a WHO guideline for building immunization records, but usually electronic registries and the supply chain of vaccines, they kind of live their separate lives. It's easily understood. Vaccines do not contain information about personal data about patients, whereas electronic immunization registries are exactly for that purpose. But when the pandemic started and what we are going through, some countries a little bit earlier, but all other countries probably are coming to this, is the largest product launch in the human history, which means that coordination between very different agencies, between different stakeholders and different layers has to be managed in order for this effort to be successful. So that what we help with is a coordinated workflows, have automated auditable processes, and secure verifiable documents like vaccination certificates, but also real-time reporting and so on. Of course, such big systems cannot be implemented everything at a time, so that what we have suggested is to start from simple things. Again, all those presentations that I've heard previous, and I hope the other in the audience as well, kind of support the case that start simple, prove that it works, and then move to the next phase, and then make use of other solutions that have available. So we're working currently also with the UNICEF, who is behind the operational management of the COVAX facility for COVID vaccinations. And in a nutshell, it's a simple way to combine the physical flow of vaccines with what we call digital twins. And when a clinic, or actually we're discussing also patients themselves, there is on the package, there is a standardized code. It's unique for each package, depending on the manufacturer. It contains 10 or sometimes less vaccines, but it is possible to verify. Is this vaccine actually authentic? And if it fails, it might mean that it has not been generated next to the physical vaccine, or maybe there is some oddity in the flow of the supply chain. Because if these scans are done, and I'm going to show in a second, for instance, starting from the manufacturer, then there is a warehouse where they are dropped for UNICEF to pick up. This is an example of a country that will work in South America, in Brazil, for example, but it would work in the same way in African countries as well. So if at that moment the visibility usually is lost, but it is possible to make those inferences based on those simple codes using just basic camera-enabled mobile phone. Again, the data that is transferred is not extensive, so it should work also in resource-constrained settings. So that the first use case is the vaccine that is actually injected genuine, or the next layer is that you can also start looking for the diversion. If, for instance, a serial number from the same package shows up in Uganda, for example, and then a day later another vaccine from the same package shows up in a another country, that is possibly an oddity which either by mistake somebody has scanned, or there are bad actors in the system that are trying to game the system. You can enable this in a simple manner by different entities, and as I said, the idea is to do it with a very simple starting point. Internet connection, smartphone with scanning feature, and then willingness to participate. So the question that was discussed earlier, okay, how to make these solutions commercially viable? Well, I believe personally is that, and this is also shown by the experience from my own country, when I said it started from being poor, is that when the services actually do deliver value, there are usually different stakeholders, either from the public sector or sometimes also in the private sector, that would take up and make these services available to all the others. The beauty of the approach is that it is also, you can extend that to other use cases, so that once the infrastructure, which is light in any way, is there, you can start building other services on top of that, like, for instance, reporting on the adverse effects, and then starting to look for the patterns if those adverse effects are related to some clinic or some vaccine or some supply chain features. And I will finish up by demonstrating what is kind of the vision or the view in the longer run, is that once again there is this physical supply, there is a flow of digital twin, and when in a hospital vaccination record is created, you have the ID, the disease, this unique vaccine number, and then you have also information about the hospital who has been onboarded. And then when you create that certificate, in our case now, we are also capable of providing the certificates which are compatible with the EU requirements, so that the entry to the country is possible with that. But important part is that if those certificates are in higher number, then we know the dosage is available from that serial number of this unique vaccine package. Again, it is possible to say that either by mistake somebody is scanning wrong vaccines, or there is indeed a bad actor in the system who is actually trying to sell or make available those certificates without the actual link to the truthful and reliable vaccines. And furthermore, what the underlying technology, which is indeed related or is from the blockchain family, if you will, you can cryptographically link the vaccination record, then take away all the personally identifiable data, so that I can already very well see how that would integrate well with the solution that Dr. Weiss just introduced. And then you have statistical reporting, if you will, but there is cryptographically one unique event that you're counting. So you can provide real-time visibility to the public health authorities, but also if there is such an agreement with the manufacturers of the vaccines, once again, it's only aggregated information. It does not contain any information about the patients, but you can see in real time the demand and the supply, and you can start planning your vaccination events and your needs for vaccines in an efficient way into the future. The solution is built on the idea that is quite well proven and established, which means that there is a distributed network of different stakeholders. Each of them has their own role. For instance, some of them with these red arrows are part of their supply of vaccines, but then there are other stakeholders, for instance, for coordination manner. There is no need for centralized repository of huge data where then everybody gets access to. No, each keeps their own data, but they are cryptographically linked only to the extent what is required for them to coordinate their activities. And then you can already see that a country or the region with different setup, again, can use it in the same way. They can then agree what is the information they want to share across the boundaries, and it does not limit only the boundaries of a geographical nature. It also means that the boundaries of private supply chains with the public healthcare systems can similarly be integrated. And in the end of the day, what the users get, for instance, are real-time graphical. These are the early pictures from Estonia, where the vaccination is happening, how it is going on, where are the vaccines located, where there is potential shortage. So I hope this was somewhat useful, and happy to take any questions now and or later during the discussion with the panel.
Thank you so much. Very, very interesting. Question number one, is this implemented anywhere?
Yes, this system is implemented in Europe, in many countries, starting from Estonia, my own country, Hungary, Iceland, and we are in the discussions with quite a few Eastern African countries to do the first pilots. And there is also first activities starting in Asian countries. So technology has been implemented quite many years, as I said, the specific application in a few countries, and we are rolling this out now in Africa and Asia.
Just next question. System looks quite interesting that it holds a lot of information, which is good data, which is also good data for the vaccine manufacturers and the health ecosystem, and they'll be prepared to pay for that data. But then now goes back to the whose data is it? And now for me, what I'm thinking in my little head, I'm thinking if this system is available, governments don't have to pay for it because somebody's going to pay for the data. I just want you to touch on it, and then I will tease Dr. Patricia to come back on it later as well.
Thank you. Once again, I've found a soulmate. I also do think that even one step further, these days, the data and the data ownership should remain where it was originally captured, and then at least when it comes to the personal health data, patients or citizens should certainly have a role in controlling that. Now, the next thing is that who's going to pay if that data is put into use? I mean, if there is an analytical value of this data, then most certainly those who reap that value, be it manufacturers, for instance, for much faster understanding of the effectiveness of their medicines or vaccines, or if the supply chain becomes more efficient because there is less waste, because there is no counterfeit, or the diversion is avoided. So this is something that we know. We are in active collaboration with AstraZeneca, Johnson & Johnson, Moderna, Pfizer just started, all who are also participating in the COVAX program. Now, this again can happen if people, citizens, and countries feel comfortable. So we get back to the governance, which has been discussed already so many times. But in principle, yes, I think that there is a lot of brain power and ideas, and I do think they would work in the real world setting as well.
Thank you. Dr. Patricia, you want to touch this? I'm sorry, I keep on teasing you back on this one.
Yeah, I think just what Dr. Ein said, I agree with it. We did call out some exceptions. So just I think to what you alluded to, if the data is already publicly available, if consent has expressly been given to, for example, a data processor, I think all of these things then mean that, that ownership then is basically shared. But then I think inherently, the data belongs to the individual, and that I think in a sense protects them from also misuse, because especially personal health records, even though they do have personally identifiable information. And even when the data is de-identified, it still remains sensitive data. And so I think that sort of that balance, creating that balance. And again, like I said, in our continent, in the practice of healthcare, in the way we treat data, those particular rights are not really enshrined. But I still believe that, as the continent is looking to benchmark against what is basically best practice globally, I believe that we should embed, for example, privacy by design in the new systems that we're building. So aspects that essentially try and ensure that rights of individuals from whom data is collected are respected.
Thank you. Thank you so much. Martin, there's just one quick question you answer before we go to Irene. Martin, the question was about the cloud. Is your cloud private or public?
At the moment, it's a private cloud. It's hosted here in South Africa. Our next year, we are implementing connectivity on all the solutions, and then the information will stay within the boundaries of each country that has a platform.
Okay, all right. There's one more question, but I think I'll cater that after we listen to Irene's. Thank you, Martin. Irene Mwoga is our next presenter.
Right. Thank you for the opportunity. So a short intro of myself. My name is Irene Mwoga. I am working with the UN Secretariat in Tanzania, the Office of the Resident Coordinator. My background from my early career was in computer sciences, and I later dived into management information systems and health informatics. I've spent most of my career in the World Health Organization, the previous 7 years in the country office in Tanzania. And just last year, I moved into the Secretariat, coordinating data and results reporting, focusing on the health outcome groups. So most of the information has been shared by Dr. Ernest and my fellow presenters. So what I'm going to recap and present are the experiences that we have learned from implementing, coordinating programs in health information systems, and drawing key recommendations of how, as African countries, we can champion the gains that we have seen in health information and move from here. I wouldn't want to dwell into the definition, but health information being a collective range of systems that collect, transform data and information. A key point for all of us to know is the ultimate goal of health information system and innovation is not to collect information or to gain information on our hands, but to improve action. Oftentimes, we are drawn into so many processes and we end up just collecting that data, and that data is not transformed into action. So why health information and innovation matters? From our experience, we often ask our member states and our program implementers, imagine a world where every baby's first cry is recorded. A baby born in Tugamo in Uganda, or in Maseno in Kisumu, or a rural village in Tanzania, if we can capture that, and that becomes part of our decision for future generations, that is value addition. And imagine when one person's illness can help prevent the sickness of every other person in the globe. Imagine a village committee who is being able to plan for health advocacy or health interventions based on the information we have collected. And we can draw into many imaginations where health information and innovation makes sense to our daily life. We're talking about cross-border information exchange. If you get sick in Rwanda and you are coming from Tanzania or any other country, the medical provision is able to provide you with the care based on historical records that is safely and easily available. All this should be on our fingertips. So we say that every person's life counts, and this is why health information system matters. And because we are in the realm of information overflow, we want to ensure that every country has better data, better information, which leads to better decisions, policies, and our ultimate goal being better health. So health information can be a powerful tool. A paramount is can, only when used properly, to make healthcare delivery more effective and far more efficient. And we have seen from the opening of Dr. Ernest that African countries are already using a lot, and we have seen a lot of benefits in the rollout of the HIS and the management information systems, EMR, decision support system, disease specific. We are now using telemedicine where expertise is cross-shared from multiple countries, even to local areas, case-based surveillance and mobile technologies. But how do we accelerate the better use of health information system in our countries? So from the programs and the experiences we have gained, we have drawn a few recommendations that we can further discuss and digest if they make sense to us for countries to adopt. First is countries should be able to show the value proposition of health information systems and innovation, because we talk so much of the role of ICT in health, the role of ICT in medicine, the role of ICT in quality of care, but only when we are able to show the value proposition that ICT adds to the general development agenda. So ICT is a tool, information is the value addition that it brings, but our overall objective should be how we transform health service provision. And this should answer into our national development plans, Agenda 2030, the regional blocks agenda. The East African community has its own agenda with the member states. West African community, ECOWAS, has the same. SADC has the same. All this should be able to show the value proposition of health information systems. And also we have the larger objective of the Sustainable Development Goals. Only when we can show return on investment, we can go to the next step of advocacy, of using our political leaders because they understand. And how do we show value proposition? The value should be appreciated by the consumers and the stakeholders who are in the realm of health information system and technology. When we are asking the clinician or the nurse in the rural village to collect vaccination data using the tablet or just putting it on paper and later keying in the computer, does she or he understand what it will turn into? Or do they do it because it is mandatory, and if they don't do it, it will bring about punishment for them? So value proposition should start to be showcased at the point of care, where data is produced, where technology is used, all the way to the policymakers. Countries need to show why they invest, the monetary value, and how value is being added across the healthcare value chain for both the public and the decision maker. So I have my two favorite quotes from the literature. They say, don't just make use of excellent technology, make excellent use of technology. And let us not forget that healthcare information technology is not a panacea for all that ails medicine. So value proposition needs to be shown in areas, not limited to what I've listed, but if we can show that it is safe to collect information. When I'm an expectant mother and a lot of my information is collected, I am hesitant and I need to know, is it safe for me to give the information that is required? Only when we can show that our patient records are kept in a safe way, our reconciliation won't be hampered. That's when we can show the value proposition. The timeliness of information at a point of care or for decision making, how effective the use of technology is aiding the clinical decision making, how efficient it is, how equitable it is in terms of being accessible to providers in knowledge. And also, how is it people-centered? Does it empower better self-care? Or is it are we using technology for the sake of saying that we're using technology? My second recommendation is once we have managed to show the value proposition of HIS, let us go back to the drawing table and address our organizational and legal frameworks. Dr. Ernest, in his opening, mentioned the contradictory legal frameworks that were there during the beginning of adopting technology in the healthcare. Right now, we need to reflect our legal frameworks, our policies, our strategies, not just within the health sector, beyond the health sector. We have the Ministry of Immigration, we have the e-government agencies, we have local government authorities, we have civil society. How are these interconnected to support an enabling environment where health technology can be used? And also, as we are talking of organization and legal frameworks, we need to make use of health information system and innovation champions. And there are many champions which can be approached. We have our political leaders, we have civil society. If a political leader can showcase the use of health information, how that information has transformed his decision to address certain interventions because of a technology that provided him data. And we know that civil society also have a very critical role in guiding and supporting government to make their decisions. So this can be our champions. Local communities, village leaders, these are our champions of health information in the organizational structure. So when we are doing our legal frameworks, let us not only focus on the management and senior leaders, let us start from the grassroots. Second input to HIS is having the appropriate tools and infrastructure. And I like, again, the opening made which mentioned that if a technology has been used by a different sector, let us not waste a lot of energy and time to build something from scratch. In the case of biometric, we have seen it across our African countries. We are striving a lot to adopt the biometric technology. The immigration department has successfully ventured into using it, and now the health sector is struggling to look for vendors and technology and forgetting that our counterparts are using it. So we need to look for the proper tools and infrastructure that support the use of ICT in health. But as we are looking for tools and infrastructure, let us not forget an important element. It is not a tool, but the human being. Who are the users and the doers? Is it something that can be easily adopted by the users, or has it been selected because it fits us as engineers or ICT specialists? So these are the things to ponder on. And third is the capacity building of staff, and staff means from the grassroots level. Our experience in implementing UN programs in country and across the regional countries is that we know that users who have been trained are more satisfied than those who have just been pushed to use. Oftentimes we may assume that mobile phones are very handy, but when we roll out the implementation of mobile health technologies, it is not as we expected, and the gains are not as we forecasted. And this training should be customized based on the roles and based on the responsibility. And once we do that, let us go back and assess the adequacy and assess if that technology is used as it should be. Our key recommendation also, particularly for this forum, is building partnerships and alliances. The successfulness of our health information system and innovation is not going to be attained when we work in silos. It requires strong alliances and partnership within the government, across the private sector, because these are our main providers, inter-regional and international bodies, civil society, because these are going to help us to leverage the use of resources. And we are also going to learn the risks from ourselves, understand the benefits. We learn and share experiences. The partnership is not just on implementing, but also in the adoption of technology. We need to focus on collaborative technologies, partnership-based and community-oriented platforms. A number of countries, I know Kenya and Tanzania have implemented health data collaborative forums which when I was in WHO, we really championed its partnership. It was a body that brought together the government, the partners, and civil society to address common priorities and common agendas in health data. And this has helped reinvestment of partners' resources to address the key priorities. So such forums and many other similar can be a very good pivot to start in building partnership and alliances so that we all rally together and move towards a common agenda. So these have been my few thoughts, and I would want to recap. It was a short presentation. We know that health information system and innovation plays a very key role in the health sector. And as East African countries, we're already on the pace to use and accelerate the benefits, but we need to maximize the gains first by showing the value proposition to the wider national development goals and global goals. We need to focus on improving our inputs, being organizational. These are the legal and structural frameworks. Focusing on the right technology. Right technology doesn't mean very complex. It can be a reuse of technology that is already being successfully applied in another sector, and also focusing on the people. Third is focusing on end user training and also building partnerships so that we move and share experiences together. The last slide is the evolution of the train. We started with very smoky trains in the 60s, and we moved to non-smoke, and now we are going to electric use. So the use of innovation and health information is an evolution. It's a journey that we learn, we relearn, we make mistakes, but also this helps us to move to a better tomorrow. So together we can make it if we make use of our collaborations like the one we are having now. And the future is bright, and we cannot do away from technology. We should always strive to show value. We should always strive to engage from user perspective before we bring in technology. Understand people's needs, understand the problem we are trying to solve, and then bring in technology.
Thank you, thank you, thank you. Members, let me just do a very quick summarization of what I've understood from here. Then I'll give you all a few minutes to say one or two things. If I go down the list, Dr. Ernest talked about innovation, focus on the job to be done. That's what I picked importantly. But what I liked most, Doctor, was imagine a digital orchestra of all digital solutions working together. Thinking of that in government solutions, and I'm thinking digital orchestra. What we have today, I don't know what it is, but I like that vision. It's good to dream about that one. Dr. Patricia, regional digital sharing, sovereignty of data, standards, critical and important. Martin, a seemingly simple solution. I think I really like that with huge impact. If you think about the simplicity of Twitter and where it has gone, I see that in, and I think the comments are clear. Very simple, but I think the impact is quite huge if we can understand how we can scale that. And I think scale is important. Dr. Sayed, you talked about the experiences of DHS2 in Western Africa. And the question is, how do we pick that up and bring it back to the rest of the continent? I like that. Dr. Alvin, really, I don't know why we can't have a solution like that in terms of we can think about the monetary side. I think if we can just go back to what Dr. Ernest said in terms of disrupt the norm and figure out how we can actually apply some of these things and bring them home quicker than basically disrupt our normal. Dr. Irene, I liked collaboration of technology. It's not a tool, but it's a human being, the user. I like that one. Digital literacy, customized training, building partnerships and alliances. Focus on the right technology and the people. I like the analogy of the evolution of the train. I've really enjoyed our discussion this morning. Members, I want to share or allow the panelists maybe a final thought. I don't see a lot of questions from the floor. I think we've done well by focusing on the floor as we went. There's a question from Felix. Are we focusing on quantitative data or qualitative data? How does we easily capture qualitative data. And I think members, please start with that. And I want to go back. I start with Irene and go back to close with Dr. Ernest at the end. So Irene, interesting question, and then also give us your comment for the rest of the presentation this morning.
Yes. So for the question from Dr. Felix, I think we are focusing on both types of data. We cannot just do quantitative. We need to focus on both. Qualitative matters a lot. How we capture that? Wow, it's a challenge, but there are many systems that are already now being on use to capture qualitative data and synthesize it to be able to inform our decisions. Am I supposed to offer my closing remarks? I think it has been a useful forum, and there's a lot of brain power within the presenters, and I also assume within the ones who are attending. If we can leverage and focus on our collaboration and building on from where we are to move, we have learned a lot. And right now we need to, if I use Dr. Felix's words, we need to face our Goliath using the skills and the tools that are already available. We don't need to build everything from scratch. A lot is already out there. So we are already on a very good pace to gain the momentum we have already started. It can be done, and we will do it. Over.
Thank you. Dr. Ain. Doctor, you are muted. Doctor, we're not hearing you. We're seeing you, but we're not hearing you. Let's come back to you after, Doctor. We can't hear you, but we'd like to hear from you. Martin, do you want to share?
Sure. Thank you. I think this has been incredibly informative. I think, like Irene said, the brain power around just this small conference is phenomenal. I think that as an African continent, we have the capacity and the skills to leapfrog available technology and do things that I think other countries would struggle to do. It might be because we're starting from a much lower starting point, but that gives us a huge opportunity in putting such technologies in place. Thank you.
Thank you, Martin. Dr. Serge.
Okay. Thank you very much. Yeah, I think as everyone said, it's been a very interesting conference, and even I was not just a panelist, I was a participant because I learned a lot. And I want to focus that, yes, we have been talking about data, and this question about data is still open, but it's also, we are trying in West Africa to move to the other sides and also trying promoting information, because we have noticed that data are being collected, data are being managed, but the information is not available for decision maker. So this is something we need always to point on, is when we are trying to build good data systems, we should also think about how we are retrieving information. So this is my take-off message. Thank you very much.
Thank you, Doctor. Dr. Patricia?
Yeah, I just want to echo my fellow panelists that this has been a wonderful session, just how we've interwoven, the broader viewpoint from Dr. Ernest, the aspects around policy and then the different interventions. And Irene's closing in terms of, how do we take this to action, I think has been really great. I think for me, it's really just to encourage us to, whilst as somebody whose day job is really around promoting scaling of innovation, sometimes we do forget the foundational aspects as a continent. While we do want to leapfrog and to take forward innovations, that there are foundational components around policy and legal and regulatory frameworks that we do need to take the time to build on, so that then that provides a shared understanding, consensus, but also a strong a strong floor on which to build on, all of these innovative approaches. So just want to sort of, continue to say that policy reform process, that building of that foundation takes a while, just the same way building the foundation of a house takes a while. But it is important for us as a continent to just make sure that we are not just producing innovation, but we also have the right regulatory and policy framework that is going to sustain and enable scaling of that innovation. But thank you so much for the opportunity to participate.
Dr. Ernest, back to you, please. Can you summarize it for us? Close it. Thank you.
Thank you so much. I think COVID-19, for all its negatives, is going to force us to do a lot of the things that we have needed to do for a long time. I implore everybody I speak to, particularly government, policymakers, decision makers, that we should not waste this opportunity by, in essence, building things vertically for COVID only that are not transferable to other needs. So, for example, when we talk about vaccination and herd immunity, we're going to put in place mechanisms, processes, modalities, technologies to reach upwards of 70% of our populations across countries, right? If we're going to actually reach and physically touch 70% of the entire African continent or more, why are we going to now forego the opportunity maybe to test those people for diabetes, or to give them additional vaccines that they need, right? Or to assess other things that they need. So I'm saying COVID is going to force us to do unprecedented things. In essence, it's going to force us. It's almost like a use case for universal health coverage. So we should use this as an opportunity now to consciously say, let us build on this investment so it holistically benefits us across all of our health needs and not just one. That said, I think on this call, we've seen a micro fraction of what's available, the capabilities, the skill set, the know-how that we have on our continent today at this moment that can solve and can help solve some of these challenges. So I feel really encouraged that we can do it, but what we need is that mobilization, that organization, that orchestra conducting that basically gets more out of us than the simple individual sum of our parts. And I think that's the piece we really need to figure out, whether it's regional initiatives like the RAD program that we heard about, what WHO is doing, what other normative and governmental bodies are driving. The thing is, we're only going to succeed if we really figure out how to harness what we have and really make this bigger than the sum of its parts. And I think that is going to be the challenge of our times if we're going to really make all this come to fruition. So it's been an honor and a pleasure to participate in this. And again, I look forward to hopefully interacting with many of you, even beyond the confines of this conference. Thank you so much.
Thank you. And I hope you enjoy the rest of the conference. And goodbye.